Morning, everyone. So let's get started with the first session on diagnosis and monitoring of glaucoma. Each speaker will speak for 20 minutes, and at the end, we're going to have 20 minutes for discussion. So I'd like to invite our first speaker, Dr. Kaweh Mansouri. Dr. Mansouri is a professor at the University of Colorado at Denver and consultant ophthalmologist in Lausanne, Switzerland. And he's going to be speaking on gonioscopy, IOP, and corneal hysteresis.
Good morning, guys. For the introduction, I'd like to thank TGF, the organizers, the planning committee, for the invitation to speak here. It is an honor to give the first presentation in these historic halls. I'm going to speak about IOP, hysteresis, and gonioscopy. These are my disclosures, none of them really relevant for this topic. Let's start with IOP. We know all, of course, that in glaucoma, intraocular pressure is only one, but of different pressures that play a role, ICP, perfusion pressure, and so on. But IOP is the only one that we measure routinely in our clinics, and the only one which we can treat. The problem with IOP is what we know about IOP reflects only part of the picture. The dark side of IOP, is that better? The dark side of IOP is quite unknown today because of our measurement methods. Let's go back in time, and I like to show, especially to our younger colleagues, to my residents in Switzerland, where does IOP, the magic number of 21 millimeter, come from? Well, it was based on a population study conducted in southern Germany by Leidecker and colleagues, where they examined about 10,000 people from the general German population, and they found that on average, IOP was around 15 millimeter mercury. Therefore, by using two standard deviations, epidemiological approach to detect abnormality, they arrived at this number of 21 point something millimeters, and everything above that was then considered as being pathological. These findings were subsequently confirmed in different countries, in US, in the Des Moines study, in UK, Bedford, in UK, Jamaica, in Greenland, Sweden, through the Framingham population-based study, and in Germany. What you see here in my annotations to these studies is that populations diverged, ages diverged, methodology by our forefathers was not very well defined as it is today, of course. For example, the study from southern Germany did not report the location where it was conducted, nor the sample size of its population. But we arrived at these numbers, and here you see from the Framingham eye study subset that these numbers, around 15 on average, 22 being 2 standard deviations away, were also observed here. Therefore, based on that, glaucoma was defined and treated at a number of 21 millimeter mercury. Life used to be easier for some of our predecessors in the 60s. These 11 glaucoma rules were defined in Germany and were thought to reflect how glaucoma could be diagnosed and treated successfully by ophthalmologists. Rule number 1 stipulated that applanation tonometry should be used at least once a year. And applanation tonometry, remember, was quite novel. Goldman had only defined it in the early 50s. Rule 4 mentioned, interesting, very specifically, that if pressure should be between 21 and 22.5 millimeters, then in presence of normal visual fields, perimetry and tonometry could be done only once a year. Let's have a look at rule number 7, which speaks now about treatment. If, again, IOP readings should be above 22.5, then start medical treatment. And first line back then, can you imagine, was pilocarpine. Here, once at night was deemed sufficient. And then rule number 10 speaks about surgery, which would be indicated if your IOP is above 26 millimeter mercury, even in the absence of more or less stable visual fields. Well, if you use 26 millimeter mercury, I don't think there would be any room for mix nowadays. And then the last rule mentions that if your IOP is stable between, again, 20 to 22.5, IOP should be done every month. So now, this was a one-size-fits-all approach to glaucoma, which of course is not valid, and thankfully so today. But we have moved away also from assuming IOP defines glaucoma. We know now that half of the patients who have IOPs above 21 may not have glaucoma in their lifetimes, and probably half of our patients who have confirmed glaucomatous visual field at optic nerve changes have IOPs below 21, at least when we measure them during the clinic every now and then with GAT. There is a clear relationship nevertheless, and this is from the Baltimore Eye study, that the higher IOP goes, the risk of developing glaucoma increases dramatically, and you see here the relative risk values from this publication. The problem with IOP is it is a very unstable biological parameter that has a circadian rhythm, which is distinct in most patients. And in the majority of patients, we see the highest IOPs at nighttime. This publication from a long time ago found also that rabbits have their highest IOPs during the dark phase, which in a way corresponds to our sleep period pressures. When these were shown in about 25 to 30 years ago at the UCSC Sleep Laboratory by Dr. Weinberg's group at John Liu, it was contested. The community was surprised that IOP was higher at nighttime. We believed that because we produce less aqueous at nighttime, IOP would be lower. So it went against the dogma, but it was shown in a clear methodologically sound manner. Pneumotonometry, reliable, documentable tonometry was used. And it was subsequently shown that the same patterns essentially reproduce in glaucoma patients as well, not only in healthy eyes. The main reason for this nighttime rise is the change in body position. So when normals or glaucoma patients assume the supine position throughout the day, then this pattern did not really occur. So when you go supine, your IOPs increase in a majority of patients. We still didn't understand why this happens because it was uncontested that we produce less aqueous at nighttime. Really, the answer I would say to that was provided quite recently by Arthur Sitt at the Mayo Clinic when they studied in healthy subjects, and they found that our uvascular outflow is essentially shut down at night. While flow is reduced by half, we knew it, your EVP remains quite stable, your uvascular outflow shuts down. And this is probably one, if not the main reason why IOP increases with this change in body position at nighttime. Now, do these IOP changes, fluctuations, circadian rhythm differences play a role in glaucoma development or glaucoma progression? We still don't know. There are many publications that look at what we call or define as fluctuation, meaning changes from one visit to another, although I would say this is not what real fluctuation is. Some of them, like this analysis from the early manifest glaucoma trial, do not find a significant correlation. Others do. And we describe these studies in this review in progress in retinal eye research in 2016 for those who are interested. Now, before coming to a close on the IOP, I'd like to mention this publication, which on a Sunday I was looking forward to read and to see some of the myths debunked in anterior segment. And I was expecting to see a few glaucoma myths being debunked. Can you imagine my disappointment when they spoke about baby shampoo and blepharitis instead, or whether topical steroids should be tapered or not? No mention of glaucoma, which I think was a big weakness of this paper. And I think 7 myths should definitely be added, which is that normal tension glaucoma would be a frequently seen form of glaucoma. I think that's a myth. This was stipulated also by Alfred Sommer 20 years ago in this nice editorial where he called for banishing the term. And it makes sense because if you obtain regular, continuous, at least 24-hour IOP measurements, you will find what we found in this one patient who was stable, had stable glaucoma. But you can see that on any chosen day, pressures vary from as low as 10 to as high as 30 or 40. So IOP is very unstable. And those patients who have normal tension glaucoma may in reality only have normal day tension glaucoma. Anyway, that's a different topic. So what do I do today for IOP? Well, we make sure to document untreated IOP for new patients, their peak IOP if available before starting treatment, define an IOP range, review it regularly if patients are stable, maybe biannually, if they're unstable, more frequently. A direct tension curve, possibly augmented with a water drinking test, is something we try in my clinic to obtain in patients who we suspect of NTG. And those patients who seem to progress despite normal pressures, well, whenever possible, we try to perform a 24-hour monitoring. We have the contact lens sensor available, or we give them the eye care home tonometer for their own measurements. And I would say my spare non-clinical time, I try to lobby industry, research agencies to put some money and efforts into developing practical, routine, ambulatory glaucoma, IOP monitoring, because I think we really need that to prepare, to treat patients better. Moving from IOP to another parameter, which is, I think, of importance, less well-studied, not routinely measured in glaucoma clinics, is corneal hysteresis. The definition comes from the Greek for lagging behind, termed in 1890. We have almost 1,000 or so publications available in ophthalmology talking about corneal hysteresis. It is a measure of the viscous damping ability of the cornea and should not, as it is often, be confounded for being an indicator of stiffness or rigidity. When the ORA was introduced, and we have now the 3rd generation, it provided us with a tool to measure this parameter and others routinely in our clinic and obtained reproducible measurements of corneal hysteresis. This publication was among the first to look at this parameter. We didn't know if corneal hysteresis would be stable throughout the day or not, like IOP, and it was reassuring in a way when John Liu and colleagues showed that corneal hysteresis does not seem to vary significantly over 24 hours. Thank God. So we can only measure one measurement and it reflects more of the image to us. This publication from the same period found a correlation between lower corneal hysteresis and association for visual field progression. So it does seem to play a role in the way glaucoma starts and progresses. Another publication from Montchoisi here from 2012, that's an important publication because in a multivariate model, they found that one of very few parameters correlated to visual field progression was corneal hysteresis. The problem with the findings was that contrary to IOP, which we can treat and modify, we cannot treat age, of course, and we can not yet treat corneal hysteresis in order to prevent progression from happening. Association also with progression was found in this study from UCSD, where those who had lower, below 10 corneal hysteresis had much higher rates of visual field progression, VFI progression, than those who had values above 10 millimeter mercuries. And also patients in this cross-sectional study from New York, patients who had asymmetric visual fields had worse or lower hysteresis in the worst eye. There's also a correlation not only between 30-degree visual field progression, but between central visual field progression, as was just recently shown in this nice publication from UCSD. Also, structural progression, and that does not come as a surprise, I would say, was shown in several publications to be correlated with corneal hysteresis. So if you have a low corneal hysteresis, you will have an eye that is at high risk for having worse visual field development and worse structural changes as well. And it goes above that. It is assumed widely that corneal hysteresis indicates the structural abilities of the eye and the laminar cribrosa in the case of glaucoma, and that it reflects which patients will be at higher risk of having worse glaucoma because of more fragile, more prone situations at the laminar cribrosa. This study found that patients with lower corneal hysteresis had a posterior anterior laminar cribrosa displacement in glaucoma, and every millimeter mercury of lower CH was associated with 0.6 micron per year posterior displacement after anterior laminar cribrosa. Can we do something about hysteresis to prevent glaucoma from progressing? Well, maybe. We know very little for now. This study from 2016 in an experimental setting tried to increase rigidity, increase stiffening of the sclera, and by doing so, stabilize eyes from progression. It is still seen with a big question mark. We don't know if that really works in a real life situation. One worry some, I would say myself, have is that we know, for example, when you smoke, that smoking probably increases the rigidity of the globe. And maybe that's why, among other reasons, why smoking has been widely associated in published studies with worse glaucoma. So 2024, what do I do about this parameter in glaucoma? Well, we know it is low in glaucoma. We know it is a risk factor for development, for progression of glaucoma. It can help us stratify which patient who is considered glaucoma suspect may progress to glaucoma, and it may affect how often we see this patient or whether we institute a treatment or we observe. To me, a suspect patient who has lower CH is a patient I would rather treat and observe closely. And if patients are younger age, have a high life expectancy, well, then the importance of this parameter is even bigger, I would say. Now let's move from these two parameters. Let's move to gonioscopy, which is not a parameter, but an examination. And we would tend, also when it comes to gonioscopy, think of Hans Goldmann as the forefather. And usually when I'm examining medical students or residents, they ask them a question of who invented or who described something, and they don't know the answer. I tell them, well, but in doubt, say Hans Goldmann, in 50% you'll be right. Well, it's not the case with gonioscopy. In fact, gonioscopy was described by Greek ophthalmologist Alexis Trantas, who coined the term in 1907. He used digital scleral indentation and the direct ophthalmoscope to observe the angle. Of course, doing so distorted the angle structures probably significantly, but it was a first. It was a first way to visualize the angle, and he subsequently managed to really produce very detailed drawings of the angle and advanced the understanding of the structure. He was limited by the concept of total internal reflection at the cornea, which didn't allow ophthalmologists to visualize the angle. And it was Maximilian Salzmann who, by using a modified keratoconus lens, managed to visualize the angle and advance this examination. Then Kaweh introduced his direct gonioscope, and when Zeiss came up with a slit lamp, then there was really a big jump ahead with gonioscopy, and several types and generations of direct and then indirect gonio lenses were introduced. And the Goldman lens was really the one that was most widely used in practice, still is, I believe. I'm going to make 3 postulates when it comes to gonioscopy. The first one is that it's probably the most difficult exam, thank you, in all of ophthalmology to perform. We can debate that later if you like, but this is my, thank you, my understanding. The second, and unfortunately related to the first, is that it is probably the most underperformed examination of ophthalmology. I believe every patient should have gonioscopy, not only every glaucoma patient, but that's not reality. And because all it takes is a single lens, which if you take good care of it, lasts for a whole career, and the slit lamp that you already have, it's probably the most cost-effective exam in ophthalmology as well. Now, why should we do ophthalmology? Of course, in order to examine the anterior chamber angle, to differentiate between open and closed angle glaucoma. Do not ever define an eye as having open or closed angles, especially open angles, if you haven't done gonioscopy. Other screening tests, such as Van Henrich, just don't have the power to do so. If you want to diagnose secondary glaucomas, then you cannot do it without performing gonioscopy. You need to obtain a good detailed view of the trabecular meshwork for different pathologies, not only glaucoma. Or when you're preparing mixed surgery, of course, gonioscopy is indispensable. And as glaucoma specialists, we forget that there are other pathologies that can affect the angle, and we should be evaluated. Now, I said it's a difficult exam to do. I tell my residents, unless you have done 500 gonioscopies, you're no way near a master in this exam. So you need to do a lot. This study from the US, which is an interesting study because it analyzed claims database with over 1 million patients in Massachusetts, found that detection of primary angle closure was performed better by ophthalmologists than optometrists. It's not very surprising, I would say, definitely for that generation, because ophthalmologists simply had a longer training in gonioscopy and had probably done on average more gonioscopies. And the same findings were seen in this study. I had to cut, unfortunately, a few slides this morning, but those slides would have shown you that also agreement between ophthalmologists is not great for gonioscopy. So that's another weakness that we have. Do we have better methods that can, that can make this exam that requires a steep and shallow learning curve become redundant? Well, I don't think we do, but we have modern technologies such as digital goniophotography and, of course, our OCTs. Let's have a look first at photography. There are different devices available, the RedCam or the Nidec GS1. They're easy to use. They provide you very good documentation for the future. They can be helpful in virtual clinics, especially in countries such as the UK, where a lot of visual clinics are done. But they have many limitations. First of all, the agreement is low for angle opening assessment when different ophthalmologists look at those photos. It was shown also that compared to gonioscopy, that detected in this study 23.4% of angle closures, GS1 only detected 4%. And when glaucoma specialists needed to compare those images with gonioscopy, agreement between specialists and among the same person was low. It was better with a RedCam, but the RedCam is a bulkier, more expensive device that I think very few of us have. AI will probably improve the performance of these devices. And one major limitation when it comes to angle closure is that, of course, you cannot perform an indentation. Now, what about our OCTs? And let me speak here only about web source OCTs, which have the best resolution for angle assessment. We have 2 FDA-approved devices in the US, more recently Anterior, before that Acacia. When you look at the table on the upper right-hand side, you see that the technical specifications are quite similar between the two. When you look lower, you see that the images that the two provide you are excellent, high quality, and similar. And in this small study from Hong Kong that compared the two to each other, it was found that both of them fared quite similarly. However, some of them provided, the anterior provided different measurements than CASIA for some parameters and vice versa. So you cannot interchange them because of those differences. They have advantages, which is that they're easy to perform by technicians. They're more widely available than the red cams. They're non-contact. Patients appreciate that. They can provide you relatively reliable angle measurements, although you need to locate the scleral spur manually for most of the time so far. They can evaluate dynamic changes, light to dark, and they can be helpful in visual clinics. However, they suffer from moderate agreement when it comes to angle assessment, and they do not provide you information on other structures, pigment in the angle, neovascularization, and so forth. So what do I do today when it comes to gonioscopy? Well, first of all, I insist on our younger colleagues to perform gonioscopy routinely. It is mandatory in our clinic for every first ophthalmic examination, annually in patients with angle closure, and before any ophthalmic surgery. I like imaging also, and we perform imaging routinely, especially when it comes to assessing angle, measuring angle before and after laser procedures, and in patients who undergo mixed surgery. Thank you very much.